الرحمن الرحيم الحمد لله رب العالمين. My dear friends, fellow students, and those who are appearing in any examination in Pakistan or outside the Pakistan, I have previously talked on Leptospirosis Session 1, and in that session I have covered the introduction, the epidemiology, the pathophysiology, pathogenesis, and microbiological aspects. The comments were given by some of my friends that they have, at one time, they have studied leptospirosis 20 years back or 30 years back, but they have not seen any case of leptospirosis in their life. So they said that why you are stressing so much time on very uncommon, or rather very, very uncommon organism. The first answer is this: the syphilis is also not seen by many of us. I have seen, but not all of us. But without syphilis, you cannot complete medicine, because syphilis should be included in the differential diagnosis of every diagnosis, because the multi-system involvement is there. Still, there are people who indulge in themselves in the sex, and people are there in the world who are visiting and who have visited the on-call sexual activities. The thing is this: the syphilis is the disease. If you forget this disease, and the patient will come to you in your clinic with some symptoms, for example, presented with aortic aneurysm. You detect it in the CT scan, and you say that why the aortic aneurysm is there, why there is aortic regurgitation in this patient, why, leading to the congestive cardiac failure. This is the importance, that should be included in the differential diagnosis of every disease. As far as this is concerned, the leptospirosis is actually sub-endemic in your country. It is sub-endemic in your country because the medical professional persons, they miss this diagnosis, because there are other diagnoses as well. For example, tuberculosis. So they go through the common one, and that is the correct way. But in the differential diagnosis, that is why I am stressing on the differential diagnosis. Okay, the most likely diagnosis, the least diagnosis, the most least diagnosis, the rare diagnosis, the rarest diagnosis, whatever it is, should be included. My slogan is this: that the short way or short paths will mislead you. You can pass the examination, but you will not become confident in your life, which may be 20 years, 30 years, 40 years, 50 years afterwards. Remember that if you are a surgeon, then again the topic is important, because there is surgical management of the infection. Infection is a very important topic in surgery also, in gynae also, in ophthalmology, in ENT. You cannot neglect it. if the geographical condition is suitable for the flourishment of the bacteria or microbiological agent, there are chances that this disease must be present or may be present in that area. For example, vectors are there, like for example, anopheles and the other one, the other vector, Glossina palpalis and other sandflies in the different parts of the country. Then there's possibility that the disease may occur because of the vectors. Dengue fever is among them. They are missing that diagnosis at one time for the 2 or 3 years, and then afterwards they diagnose the dengue fever. Again, the chikungunya will be diagnosed like this. Zika fever, for example, still there is no evidence. Only 2 or 3% were detected in AQH as a Zika fever, not dengue fever. The vector is the same. So I mean that this area in which we belong actually, Sindh area, for example, or Karachi, if the environmental condition and geographical condition are there are chances of the leptospirosis is there. You cannot neglect this disease. You can pass the examination, but you are not confident, will not be in good confidence to the patient is concerned, because the end beneficiary is the patient. You are misdiagnosing that patient. You start treatment, for example, for the chronic renal failure because of some calculus, let's say for some other infections, common infections. But in the end, they are not responding, and again, the case will be closed and or be referred to the other one. So a chain is formed. The one person is going to one clinic and another clinic and another clinic, etc. So that's why I am doing this. This is the main aim of mine. That every student of medicine, I am the student of medicine myself. I am Professor Alihaidar. I am honorary global professor of medicine without any name, fame or economics. I am speaking and making slides in these shows, taking hours to make these slides for you people, for the sake of the Pakistani population, the end beneficiaries. So be careful that you should understand the disease, that is leptospirosis, completely. I will say completely, so that from every angle you should know about it. If you are giving examination, if you are a physician, you should understand what are the essentials of diagnosis. This is the thing. Essentials of diagnosis will lead to the diagnosis. Let us start now on a story. A 45-year sewerage worker, chain smoker, he was alcoholic, who recovers from the carbon monoxide poisoning 7 days ago, developed high-grade fever with macular pink rashes associated with the productive cough. He developed severe headache and diarrhea with decreased output of urine. And he arrived in the emergency department with hemoptysis, and that is why he arrived. Otherwise, the general practitioners were dealing with his patient as a patient of the probably a viral infection, for example, or some other infection in their mind. In the end, they are also doing the tests for the mycobacteria. But in emergency department, we examined that patient. The temperature was 104, the pulse was 106. It was regular and a good volume. BP was 86/45. Severe dehydration, with subconjunctival hemorrhages, pedal edema, jaundice, hepatomegaly of 2 centimeter, coarse crepitation all over the chest, hemoglobin 12 gram, TLC 19,000, neutrophil 75% around. It is the neutrophil leukocytosis. Lymphocyte 21, eosinophil 3, the basophil 1. Reticulocytes are 8%, they are higher. The random blood sugar was 150, sodium was 126, lower down. Again, my question is the same one, why there is hyponatremia in this patient? Potassium is 5, almost higher level, but it's normal. Chloride is 100, normal. Carbonate is 32, it is alkalosis. Saturation is 86, SPOT, oximeter. It is lower down. Total bilirubin is 5.5, direct was 1.3, minus it was predominant indirect hyperbilirubinemia, means hemolysis. Because the other enzymes, ALT 53, AST was 47, ALP was 108, within normal range. Gamma GT is slightly raised to 60. Not significant increment. XHS, there are diffuse micro and macronodular scattered opacities all over the zones. All lung zones are involved like this. There are macro and there are macro opacities. Macronodular. It is not reticular nodular. It is micro plus macronodular opacities. These are the artifacts. Okay? Now this is the one X-ray which is shown to you to understand. There is haziness, although all the upper parts are not involved here. The air is there, patches are there, air patches between them, but both sides are involved. So it is a mixed macronodular, bilateral, global opacities. So you all know there are differential diagnoses. Acute inflammation or the result of acute inflammation, the chronic inflammation or the result of the chronic inflammation, the tumor and tumor-like stage and the complications, and the other rare or uncommon conditions like Loeffler syndrome, etc. Pneumoconiosis, sarcoidosis. This possibility of every diagnosis, because this is what is shown here, is the opacities. पेशेंट इतना बीमार नजर नहीं आएगा आपको जितनी के भयानक एक्सरे होगा. इसमें तो ये लगता है कि ये आदमी जो है ना बस दमखम ख़त्म हो इसका. Patient is not so much serious than the X-ray, which is horrible. And ये एक इम्पोर्टेंट बात है, ये अपने ध्यान में रखिएगा कि ऑल ओवर पेशेंट को देखा जाता है एंड देन फिर डिसाइड करते हैं हम. तो क्लिनिकल अप्रोच जो है वो टॉप पे होती है, फिर बाद में चीज़ें शुरू होती हैं. अगर आपसे कहा जाए ABCDE में कि सबसे ज़्यादा इम्पोर्टेंट आपके पास टूल ऑफ डायग्नोसिस क्या था, तो हमेशा याद रखिए किसी भी डिजीज़ के बारे में अगर उन्होंने क्लिनिकल अप्रोच लिखी हुई है तो उसको टिक करना है. PCR को टिक नहीं करेंगे कभी भी, इसलिए कि क्लिनिकल अप्रोच जो अपर हैंड रखती है हमेशा. फिजिशियन की एक्सपीरियंस पर डिपेंड कर रहा होता है, उसकी पेशेंट की प्रेजेंटेशन पर डिपेंड कर रहा होता है. Now, clinical presentation, the symptoms of the leptospirosis usually appear 1 to 2 weeks after infection. The incubation period can be as long as a month. It's possible. He is living in the sub-endemic area, the person. The illness is biphasic in the majority of the symptomatic cases. Means that it is the patient become all right and then again become ill. In the majority of the symptomatic cases, symptoms of the first phase, that is called the acute or the leptospiremic phase, that is the bacteremic phase, lasts about 5 to 7 days. In the second phase, and the fever goes down afterward, the second phase starts, that is called immune phase, the symptoms resolves as the antibodies against the bacteria are produced. So the patient will become beneficial. Additional symptoms develop in the second phase. The phase of the illness may not be distinct, especially in patients with severe illness, and 90% of those infected experience mild symptoms, while 10% experienced severe leptospirosis. वो सेम है जो है ना चेन ऑफ इन्फ्लेमेशन है, बैक्टीरिया, सेप्टिसीमिया, पाइमिया, SRIS, फिर उसके बाद जो है वो सेप्सिस है, सेप्टिक शॉक है, MODS है, इरिथ्रोफेगोसिटिक सिंड्रोम है, ये सारे जो है ना चेन ऑफ रिएक्शन, चेन ऑफ इन्फ्लेमेशन है, ये सब इसमें पाया जाएगा. उससे जो है ना सिविरिटी का आपको पता चलता है. द लेप्टोस्पाइरल इन्फेक्शन इन ह्यूमन्स कॉज अ रेंज ऑफ सिम्टम्स. Some infected person may have some none. The disease begins suddenly with fever accompanied by chills, intense headaches, severe muscle aches, and abdominal pain. Abdominal pain, again, with the presentation. Muscle aches can occur in any condition, which causing the bacteremia. A headache brought on by leptospirosis causes throbbing pain, and is characteristically located at the head's bilateral, temporal, and frontal regions. The person could have pain behind the eyes, retrobulbar, and a sensitivity to the light, that is photophobia. Muscle pain usually involves the calf muscles and the lower back. The most characteristic feature of the leptospirosis is the conjunctival suffusion, conjunctivitis without exudate, which is rarely found in other febrile illness. Only suffusion is there, but without any exudate. Other characteristic findings in the eye include the subconjunctival bleeding and jaundice. A rash is rarely found in the leptospirosis, although when one is found, alternative diagnosis such as dengue fever or chikungunya fever should be considered. More likely is dengue fever or chikungunya, or is Zika, it is possible. But as the disease progresses, this diagnosis will be changed. Dry cough is observed in 20 to 57% of people with leptospirosis. Thus, the clinical feature can mislead a doctor to diagnose the disease as a respiratory illness. Mislead as RTI. Additionally, the gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and diarrhea frequently occur. Vomiting and diarrhea may continue to dehydration. The abdominal pain can be due to the acalculous cholecystitis, which is commonly seen here, or inflammation of the pancreas, pancreatitis is common. Rarely the lymph nodes, liver, and spleen may be large and palpable, just like in this case they are palpable. It is the presentation. Acute phase, fever and headache, conjunctival suffusion was shown, jaundice, photophobia, cough, abdominal pain and vomiting, pancreatitis, acalculous cholecystitis without any calculus, diarrhea, muscle pain, skin rash, which is rare although. Immune phase, meningitis can occur, encephalitis can occur, meningitis can occur, meningoencephalitis can occur, lungs, bleeding, myocarditis is rarely seen, but it is one of the differential diagnoses of the myocarditis. Now, liver failure, stomach bleeding, leading to possibly of the hematemesis or the melena, kidney failure, this is many important point. The kidney failure, whether it is pre-renal or renal, possibility of the pre-renal or renal, depending upon how much heart is involved. Melena and bruises. This is subconjunctival suffusion and subconjunctival hemorrhages. And then there will be resolution of symptoms for 1 to 3 days. The immune phase starts after this, and then it lasts from 30 days and can be anything from the brain to the kidney complication. Because of the antigen-antibody reaction, it is an immune reaction. The hallmark of the second phase is the inflammation on the membranes covering the brain. That is meningitis Signs and symptoms of meningitis include the severe headache and neck stiffness. Kidney sign may or may not be positive. Kidney involvement is associated with the reduced or absent urine output, anuria or oliguria. The classic form of the severe leptospirosis is known as Weil's disease. Remember this, Weil's disease. Severe leptospirosis is known as Weil's disease. It is characterized by liver damage causing jaundice, kidney failure and bleeding, which happens in 5 to 10% of those infected. Lung and brain damage can also occur for those with the signs of the inflammation of the membranes covering the brain and the brain itself. Altered level of consciousness can happen. So the Glasgow coma score will be going down and down. A variety of the neurological problems such as paralysis of the half of the body, complete inflammation of the whole horizontal section of the spinal cord, transverse myelitis that is called, and muscle weakness due to the immune damage of the nerves supplying the muscles are the complication of this phase. And the signs of bleeding such as non-traumatic bruises at about 1 millimeter, non-traumatic bruises more than 1 centimeter, nose bleeding, blackish stools due to bleeding in the stomach, vomiting blood, hematemesis, bleeding from the lungs, hemoptysis can also be found. The prolongation of the prothrombin time in coagulation test is associated with severe bleeding manifestation. I have told you in the session 1, but they are disturbed. The clotting mechanism is disturbed. However, the low platelet count is not associated with severe bleeding. Leptospirosis can cause, remember, the disseminated intravascular coagulation also. However, low platelet is not associated with severe bleeding. There are other causes of bleeding rather than the thrombocytopenia. Pulmonary hemorrhage is alveolar hemorrhage, bleeding into the alveoli of the lungs, leading to the massive coughing up of the blood and causing acute respiratory distress syndrome, now ARDS. ये सारी चीज़ें वही आ गई हैं जो कि वायरस जिससे इन्वॉल्वमेंट हुआ है लोगों को 2 साल में, that is coronary, where the risk of the death is more than 50%. Rarely, inflammation of the heart muscle, inflammation of the membranes covering the heart, that is pericarditis, abnormalities in the heart's natural pacemaker, and abnormal heart rhythm occur, 1st degree heart block, 2nd degree heart block, and in some cases the 3rd degree heart block can be seen. The diagnosis is lab test. I already told you that the hemoglobin level may be possibly low, not much low. Leukocytosis will be there, possibility of the thrombocytopenia, possibility of the bone marrow suppression, marrow suppression leading to the pancytopenia, and ESR and C-reactive protein may also be elevated. Acute phase reactant will be raised. Kidney is commonly involved in the leptospirosis and urea and creatinine levels will be elevated. Leptospirosis increases the potassium excretion in the urine, which leads to the low potassium level in the second phase of the disease, and a low sodium level in the blood. Urine analysis may reveal the presence of protein, white blood cells, and macroscopic hematuria. Because of the bacteria settle in the kidneys, urine culture will be positive for leptospirosis starting for the 2nd week of illness until 30 days. And this is very important clue to the diagnosis. If the culture can be done properly. For those with the liver involvement, transaminases and direct bilirubin are elevated in the liver function test. In the second phase, not in the first. The hemorrhage serogroup is associated with Leptospira ictiohemorrhagica, that is the subspecies serogroup. The jaundice and the elevated bilirubin levels, always there. Hemolytic anemia contribute to the jaundice. The main thing is the hemolysis. A feature of leptospirosis is acute hemolytic anemia and conjugated hyperbilirubinemia. Both are seen in the second phase, not in the first phase, especially in the patient with the GCPD deficiency. And serum amylase, serum lipase level may be increasing, showing that the pancreas is involved. Creatinine clearance will be reduced to 50 ml from 100 ml per minute to 50 ml per minute. For those with a severe headache who show the signs of meningitis, lumbar puncture can be attempted. If infected, CSF examination shows lymphocyte predominance, cell count of about 500 per cubic millimeter. Pleocytosis with the dominant lymphocytes. Protein between 50 to 100, protein will be raised, but the glucose level is normal, although it is gram-negative involvement. This is a very important point. These findings are consistent with the aseptic meningitis rather than the septic meningitis because glucose levels are normal. The aseptic meningitis commonest cause is virus. Serology can be done, ELISA can be done, and it is IgM should be sought out rather than IgG. Other latex slide agglutination tests are also there to diagnose this condition, although the false positive serologies are there. One examination is called the MAT, the microscopic agglutination test. It is the reference test for the diagnosis of the leptospirosis. MAT is a test where the serial dilution of patient sera is mixed with the different residuals of the Leptospira, Actinohemorrhagica, etc., etc. The mixture is then examined under a dark field microscope to look for agglutination. This is very important examination, dark field microscope. The highest dilution, the 50% of agglutination occurs in the result. The MAT titers of 1:100 or 1:800 are the diagnostic of leptospirosis. A fourfold or greater rise in the titer of two sera taken at symptom onset and 3 days to 10 days of disease onset confirms this diagnosis. During the acute phase of the disease, first phase, MAT is not specific, detecting the serotype, but in second phase it is the diagnostic. Remember this test, the microscopic agglutination test. Now here you see the direct evidence in this. If you see this direct evidence, you can go for the sputum examination, for the urine examination, or other lesions. Direct evidence. Stain it in the ground, and you see this bacteria, this one, and which is a spiral shape, penetrating into the tissues. Molecular tests, PCR, are there. You can detect from the urine, from the sputum, and from the CSF, etc. And it is definitely a very, very specific test. Although false positive can occur. Diagnosis in the radiological diagnosis is again the same as, say, the macronodular type of obesities in the chest X-ray, excluding the other diagnosis, is helpful. Diagnostic criteria is called the Fain's criteria according to WHO, in which consists of 3 parts. A is clinical findings, B epidemiological factor, C lab findings and bacteriological data. Clinical findings are the upper hand. तो लिस्ट है पूरी. बी एपिडेमियोलॉजिकल फैक्टर आपके यहाँ मौजूद है. ये जियोग्राफिक ये एरिया बहुत अच्छा है फॉर दी फ्लरिशमेंट ऑफ द लेप्टोस्पायरा. तो एपिडेमियोलॉजिकल फैक्टर तो हैं. सी में लैब फाइंडिंग एंड बैक्टीरियोलॉजिकल डेटा आपके पास चाहिए. और ये तीनों चीज़ें आप मिला देंगे तो फिर फेन्स क्राइटेरिया हो जाएगा. ये मॉडिफाइड किया इन्होंने एमएटी के साथ कि उस वक्त माइक्रोस्कोपिक एग्लूटिनेशन टेस्ट को इंक्लूड किया है इसमें, इसके सी के अंदर. और फिर इसके बाद और मॉडिफाइड किया इसको. जब उनका पीसीआर आ गए और दूसरी चीज़ें आ गई टेस्ट परफॉर्मेंस की, तो उसके अंदर फिर इसको एक्सक्लूड किया इन्होंने. मैट को स्लाइड एग्लूटिनेशन टेस्ट और दूसरे टेस्ट इसमें शामिल कर लिए इन्होंने. अमेंडमेंट इसकी की गई है. अब क्लिनिकल जो है डायग्नोसिस में एक पेशेंट जो आपके पास आता है उसको कुछ भी हो, चाहे लुगीरी हो रहा हो या इसको जो है वो भेनिना हो रहा हो, फीवर हो रहा हो और शॉर्टनेस ऑफ ब्रेथ और हेमोप्टाइसिस के साथ आया है एक्यूट कंडीशन में, तो आप इस डायग्नोसिस को ध्यान में रखेंगे. ये फेन्स मॉडिफाइड क्राइटेरियाज हैं. फेन्स मॉडिफाइड क्राइटेरियाज आर यूज्ड नाउअडेज. मैनेजमेंट इसकी बहुत आसान है. आपके पास बहुत अच्छे टूल्स हैं, एजिथ्रोमाइसिन है, एम्पिसिलिन है, अमॉक्सिसिलिन है. अब इसके अंदर जो सबसे अच्छी जो ड्रग इस्तेमाल की जाती है वो डॉक्सीसाइक्लिन है, विब्रोमाइसिन, 2 मिलीग्राम पर किलोग्राम बॉडी वेट। 50 किलो का आदमी है तो 100 मिलीग्राम हो जाएगी, ज़्यादा है तो फिर इससे ज़्यादा हो जाएगी डोज। 100 मिलीग्राम 12 आवर्ली इसको देते हैं 5 to 7 days फॉर दोज माइल्ड लेप्टोस्पायरोसिस में, जबकि टेट्रासाइक्लिन, एम्पिसिलिन एंड एमॉक्सिसिलिन कैन आल्सो बी यूज्ड अनस्टेड इन एरियाज वे रिकेट्सिया एंड लेप्टोस्पायरोसिस बोथ एंडेमिक, क्योंकि वहाँ पे भी जो है वो रिकेट्सिया में जो टिक बॉर्न रिकेट्सिया इन्फेक्शन होते हैं, आपको पता है, स्क्रब टाइफस वगैरह, इसलिए जो है ना ये ड्रग दोनों में इस्तेमाल की जा सकती है। एजिथ्रोमाइसिन एंड डॉक्सीसाइक्लिन को कंबाइन कर दें अगर आप, तो ये स्ट्रॉन्ग जो है ना आपके पास एंटीबायोटिक ट्रीटमेंट हो जाएगा। और ये याद रखिएगा, जब जितना तेज़ी के साथ आप किल करते हैं ऑर्गेनिज्म को, उतना ये ज़्यादा से ज़्यादा जब ये लिबरेट करता है अपने एंटीजेंस को, तो जेरिक्स एक्जिमर रिएक्शन हो जाता है, फीवर हो जाता है पेशेंट को, रैशेस हो जाते हैं, और उसको फ्लशिंग ऑफ द फेस हो जाती है। ये सारी चीज़ें जेरिक्स एक्जिमर रिएक्शन में हो जाती है। तो जेरिक्स एक्जिमर रिएक्शन किसी भी डिजीज़ में हो सकता है जिसके अंदर जो किलिंग आप कर रहे हैं किसी भी माइक्रो ऑर्गेनिज्म की और बहुत तेज़ी के साथ किल हो रहा है, उसमें जेरिक्स एक्जिमर रिएक्शन हो सकता है। ये सबसे पहले जो रियाज किया था इन्होंने माइक्रोफैलेरिया में किया था जेरिक्स एक्जिमर रिएक्शन। बाद में ये मालूम चला कि दूसरी डिजीज जहाँ पे भी किल किया जाए बैक्टीरिया को, वहाँ पे हो जाएगा। इसके अलावा जो मैनेजमेंट, इसके बाद आपको बताया कि एक्यूट रीनल फेलियर है तो उसको मैनेज करें, हाइपर कैलेमिया को मैनेजमेंट करें, वही पुरानी बातें। जनरल मेजर्स करना है, स्पेसिफिक मेजर्स करना है, अपने प्रिवेंटिव मेजर्स करना है इसमें। फिर इसके अंदर जो है वो दूसरे जो मैनेजमेंट आपको सर्जिकल मेजर्स है, लोकल मेजर्स वगैरह वगैरह। स्टेरॉइड्स हैव बीन प्रपोज्ड टू सप्रेस इन्फ्लेमेशन लेप्टोस्पायरोसिस। असल में इसको इसलिए देते हैं कि इसको बचाने के लिए देते हैं DIC से, डिस्ट्रीब्यूटेड इंटरवास्कुलर कोगुलेशन, जैसे कि आप दे रहे थे कोरोना रेडी में। स्टेरॉइड्स का क्या रोल था? इसलिए रोल था कि वो उसको बचा ले, आगे ना जाने दे, वो साइकिल तोड़ने के लिए आप इस्तेमाल कर रहे थे। तो यहाँ पे भी सेम रोल है स्टेरॉइड्स का। प्रिवेंशन इज़ बेटर देन क्योर। आप अपने हाइजीन अच्छा रखें, इम्प्रूव हाउसिंग करें, इंफ्रास्ट्रक्चर करें, सैनिटेशन स्टैंडर्ड अच्छा रखें, और जो लोग इसमें इन्वॉल्व हैं उनको आप उनसे मोहब्बत रखें, उनको प्यार दें, जो उसकी सफाई करते हैं, जिनको आप कहते हैं कि ये सैनिटरी वर्कर्स हैं, उनसे जो है ना उनको फैसिलिटी प्रोवाइड करें, उनकी तनख्वाहें बढ़ाएं। वो रिस्क पे होते हैं, वो हाई रिस्क पे होते हैं। इसलिए जो है ना ये इम्पोर्टेंट बात है, उसकी प्रमोशन इम्पोर्टेंट बात है, उनकी ख्याल रखना और उनको बताना कि भाई हाथ धोने हैं, क्या करना है, सारी चीज़ें इसमें आ जाती हैं। और लोगों को भी बताना कि ये भी कोई डिजीज़ होती है लेप्टोस्पायरोसिस। एक्चुअली वैक्सीनेशन इसमें इतनी कामयाब नहीं है, क्योंकि अपनी जो मॉर्फोलॉजी वो बदल लेता है। तो इन्होंने बहुत ट्रायल किए हैं, ट्राइवेलेंट वैक्सीन्स इन्होंने बनाई हैं 3 सीरोवर्स के लिए, लेकिन लॉन्ग लास्टिंग अभी तक नहीं बना पाए हैं वैक्सीन्स। अभी भी ये फेज़ जारी है, ख़त्म नहीं हुआ। दे आर डूइंग इट कि कोई ऐसा वैक्सीन बनाई जाए जो कि सैनिटरी वर्कर्स को या लैब वर्कर्स को लगाई जा सके कम से कम। इसके अलावा जो है जो कीमोप्रोफिलैक्सिस आप देते हैं, इसकी जगह अगर आप नहीं वैक्सीन बना पा रहे हैं तो डॉक्सीसाइक्लिन इन वीक दे दें प्रोफिलैक्सिस उन एरिया में जो एंडेमिक एरियाज हैं या सब एंडेमिक एरियाज हैं। कम से कम लोगों को हफ्ते में 1 मरतबा दे दें। ये जो जौड़ हैं और ये बस्तियाँ आबाद हैं कराची में, जहाँ पानी जमा हो जाता है गटर का, अगर वहाँ ये तकसीम कर दें आप और लोगों को बताएं हफ्ते में 1 दफ़ा गोली खा लो, जब तक 3 महीने 4 महीने यहाँ पे गटर का पानी जमा है, तो ये बचा जा सकता है। सैनिटरी वर्कर्स हैं उनको आप दे दें। और फिर ये जो है कि जहाँ पे भी जो है ना यहाँ आप समझते हैं कि सबसे ज़्यादा डेंजर है, वहाँ पे ये आप निशान लगा दें, जैसे कि इन्होंने लगाया है। और ये लगाने का मकसद ये है कि वार्निंग करना है। कीनिया है, दूसरी जगहों पे ये लगे हुए हैं इस तरह के बोर्ड्स। इसी तरह से यूरोप में और अमेरिका में भी बोर्ड्स लगाए हैं कि इस जौहड़ में, इस झील में नहाना मना है, क्योंकि यहाँ पे लेप्टोस्पायरोसिस को कल्चर कर चुके हैं। तो कल्चर करते रहते हैं, उनकी टीमें जो है एपिडेमियोलॉजी वाली वो जाती रहती हैं। हमारे यहाँ इस तरह का एपिडेमियोलॉजिस्ट स्कोप है ही नहीं। हम ये तो कर सकते हैं कम से कम उन जगहों पे ये लगा दें बोर्ड्स जहाँ से ये डिटेक्ट किया गया है। कम से कम 12, 14, 15 जगहें तो हैं जहाँ लोग पिकनिक स्पॉट्स हैं मिसाल के तौर पर, जहाँ लोग ज़्यादा जाते हैं, और वहाँ पे कल्चर करके देख लें। अगर कल्चर में पॉजिटिव आ रहा है ये, तो फिर वहाँ पे बोर्ड लगा दें और वहाँ पे वर्कर खड़े कर दें कि यहाँ नहाना मना है, तो ये बचा जा सकता है। आई होप कि ये लेक्चर थोड़ा सा लंबा हो गया होगा और ज़्यादा अच्छा नहीं होगा, ड्राई होगा ये बहुत, मगर ये इम्पोर्टेंट बहुत ज़्यादा है। ये मैं आपको बता दूँ, अगर मैं एग्जामिनर हुआ और मेरे पास लेप्टोस्पायरोसिस की डिफरेंशियल आ गई तो मैं पूरी की पूरी तरह से अच्छी तरीके से जो है वो सारी की सारी जो है ना इन्फॉर्मेशन कैंडिडेट से ले लूँगा, और अगर नहीं बताएगा तो फिर वो दोबारा वापस जाए और तैयारी करे, पढ़े और फिर वापस आए। वमा अलैना इल्लल बलाग। अस्सलामु अलैकुम वरहमतुल्लाहि वबरकातुहू।